Good afternoon, everyone. Now I'm going to present a case. A woman, Mrs. A, 25 years primary gravida at around 36 weeks gestation. She was referred from an outside hospital in view of eclampsia for further intensive care management. On arrival to our emergency, she was irritable and confused with a GCS of E4, V5, M6. This pallor and pedal edema up to the level of the knees. Her vitals are like pulse is around 110, BP 160, 100, SpO2 around 82 to 85. And on auscultation, bilateral clefts were present and cardiac heart sounds were heard. On perabdomen examination, uterus is term size, cephalic, relaxed, and fetal heart sounds are heard. On pervaginal examination, cervix is os closed, uneffaced, vertex at -3 station, and there's no evidence of bleeding or leaking PV. She had no history of previous high blood pressure recordings before in this pregnancy. The insult started as she complained of pain abdomen and uneasiness, and she threw a fit at home with frothy discharge and vomiting. Later she was taken to a nearby hospital. Her status at that hospital was she was conscious, confused, pulse around 100, BP 200 by 110 mm of Hg, SpO2 around 92% and GRBS 140. She was stabilized there by giving injection labetalol, magnesium sulfate loading dose and lorazepam. She further had 2 episodes of seizures at that hospital, and then she was referred to a higher center. The history in the present pregnancy, it is almost normal. She had regular ANCs from the 3rd trimester of pregnancy. All the scans were normal, and she had no history of GDM or raised blood pressures according to her previous records. On arrival to our hospital, she was evaluated, investigations were sent, and she was started on ventilatory support. Magnesium loading dose was started, labetalol infusion and Levipil was started. And in view of eclampsia, she was taken up for emergency LSCS and delivered a live baby girl at around 2.8 kgs. And further which she recovered, and she was extubated the next day. Later she recovered well, and on the 4th POD she was discharged and shifted to the KMC ward for the baby side. And on 8th POD, while she was still in the hospital, she developed shortness of breath, and her vitals were like pulses around 120, BP 130, 80, and on respiratory examination, bilateral cramps were present. Keeping in mind the DDs as pulmonary edema, peripartum cardiomyopathy, pulmonary embolism, and sepsis, we investigated her, and the investigations were like this. The hemoglobin is 9.3, total counts are 8,000, sugars are normal, creatinine is normal, CRP is 40, and NT-proBNP is 8,500. On ECG, it's sinus tachycardia, and on chest X-ray, it showed signs of pulmonary edema. Her echo on admission showed adequate LV function, and there's only mild TR and mild PAH. Apart from that, it looks normal. But on 8th POD, it showed marked global hypokinesia of left ventricle with moderate LV systolic dysfunction, and left ventricular ejection fraction is around 35%. She had mild MR and TR, and we came to the diagnosis of postpartum cardiomyopathy, as the left ventricular ejection fraction is markedly decreased and there is marked global hypokinesia. And we managed her with, we shifted her to the MICU care, and we managed her with oxygen support and NIV and injection diator, aldolactone, metoprolol, and a Sidmus was added during the time of discharge. Now, I would like Dr. Ramarao sir, our senior cardiologist, to give us insight onto this case.
Good afternoon, everybody. So, for the next 5 minutes, I will briefly discuss about the peripartum cardiomyopathy. So, actually, it is the diagnostics of exclusion. So, what are the criteria? All these things in the next 5 minutes we will discuss. So, as per the ESC guidelines, peripartum cardiomyopathy is an idiopathic cardiomyopathy with the following characteristics: So development of heart failure towards the end of the pregnancy or the within 5 months following the delivery, and absence of any another identifiable cause for the heart failure, and LVEF should be less than 45% with or without LV dilatation. So this is the criteria it was given by ESC. Coming to the epidemiology, so it is highly variable. It is mainly dependent on geographic area and races. So very highest in Nigerian population, which is 1:100. Whereas if you come for Japan, it is 1:20,000. In US, it is approximately 1:10,000. Coming to the risk factors, so it can be divided into two types: probable and proposed risk factors. The probable risk factors like twin pregnancy, high parity, then high gravidity, then extremes of reproductive age more than 30, and prolonged tocolytics with beta agonist, then preeclampsia. So genetics, so some of the genes which are involved in DCM, they are also known to cause the PPCM and obesity. And proposed risk factors like smoking, hypertension, malnutrition, cocaine abuse, African ancestry, and low socioeconomic status. So if you ask pathology, actually it is not clearly known and it is always multifactorial. So there are different theories are proposed. So one is the myocardial inflammation and oxidative stress, and second thing is the prolactin fragmentation hypothesis. So during delivery or after delivery, prolactin is secreted, which when it is fragmented to 16K DA prolactin segment, so that is known to cause decrease the VEGF and myocardial inflammation and decreasing the LVEF. And another thing is angiogenic imbalance, and other factors like genetic and autoimmune factors and hemodynamic stress of pregnancy also has been proposed. Coming to the symptoms and signs, see whatever the so the patients will have routine heart failure symptoms. The problem is even pregnancy people also will have similar kind of heart failure features like routine dyspnea, cough, like pedal edema and all these things. So you need to have thorough evaluation and examination and routine echocardiography. Otherwise, you will miss the diagnosis very easily. That's why actually the incidence of peripartum cardiomyopathy is much higher than it is calculated, because the symptoms are both are similar. So most of the times mild cases we will miss it. So the routine symptoms are dyspnea, cough, orthopnea, PND, pedal edema and hemoptysis. And physical signs, if you come across, then they will have tachycardia, raised JVP. So whenever there is a LV dilatation, a displaced apical impulse, third heart sound, and a MR will be there whenever there is a severe MR. And so whenever they have severe LV dysfunction, they can have thrombus formation even left as well as right side of the heart, and it can lead to embolism. So coming to the diagnosis, actually peripartum cardiomyopathy is a diagnosis of exclusion. So whenever these symptoms are there, so we need to check the routine, what are the other things it can mimic like this. So what is the most common thing is pregnancy, delivery and all these things. First thing we have to consider is the anemia. So second thing is the sepsis. Then third is the pulmonary embolism. Then fourth one is the, if there is what we call previous history of any valvular heart disease or any dilated cardiomyopathy is there, that also you need to check. So if all of them are not there, then only we have to come for the PPCM. So if you come for the ECG, so ECG you won't find much findings except like sinus tachycardia with LVH strain pattern with mild prolonged PR interval. Other than that, you won't find much factors. And 2D echo is most sensitive and specific. So here the LVEF is decreased, and the pattern of LV dysfunction also here is peculiar. Here the LV dysfunction is more of generalized rather than regional, and they will have similar picture to DCM. So all chambers of the heart are enlarged, but it is not always. So maybe 30 to 40% only you will have dilatation of the all chambers. So remaining people, they will have only dilatation of the left ventricle and left atrium and the dilatation of the left ventricle. Some of the patients, they can have severe MR and TR and the EF is less than 45. And whenever they have arrhythmias, severe LV dysfunction, they can have the LV thrombus. So all these things we need to see. So this is the picture of, so one is the left side is the normal one and right side is the, so PPCM heart picture where we can see the dilatation of the all four chambers. Coming to the biomarkers, NT-proBNP it is not specific, but it is highly sensitive. And CRP is useful to diagnose sepsis as well as for the prognostication of the disease. And 16K DA prolactin, it is not done routinely. If it is available, that is also sensitive. So once you made the diagnosis, so mostly it is clinical and echocardiographic finding only the PPCM diagnosis. Once we have made the diagnosis of PPCM means next what? So management is, so we have to divide the management into three categories. Like one is first what to do for decreasing the symptoms. Next is the slowing the progression of the LV dysfunction. Third thing is the improving the survival. So it is a multidisciplinary approach by the obstetrician, cardiologist as well as the anesthesiologist. So once you diagnose the patient of PPCM, first we have to make diagnosis whether the patient is in cardiopulmonary distress or not. So how to make cardiopulmonary distress is there or not. So we have to see whether any tachycardia, tachypnea, hypoxia, hypotension, decreased urine output, then altered mental status, and elevated lactates. So if any of the findings are there, then we have to conclude that the patient is in cardiopulmonary distress. Because if the patient is in stable and if the patient is in distress, the treatment will be various. If the patient is in distress, so first we need to optimize the patient. Suppose the patient is in pulmonary edema means we have to give the diuretics. If the patient is dehydrated means we have to give the volume and keep the BP around 110 and optimize the oxygenation. So if necessary, we have to go for the BiPAP or ventilator, rarely VA ECMO also. Then if patient is in hypotension, then we have to consider for the inotropes. And here the most important thing is, apart from routine inotropes, if BP is permissible, then we have to consider the levosimentamine. That is the drug of inotropes. And whenever the patient is in hemodynamic compromise, so we have to go for the urgent delivery, preferably cesarean section. And whenever the LVEF is very low and the patient is in severe PPCM, then we have to consider the bromocriptine. However, the role of bromocriptine is controversial. And if the patient requires, we have to go for the ventilator support. And once the patient recovers, then we have to wean off the treatment. If doesn't recover, then we have to go for the transplantation. In US, I think fourth reason for the cardiac transplantation is the postpartum cardiomyopathy. So if the patient is if stable, then we have to divide the patient into two categories, again antepartum and postpartum. If the patient is in antepartum, then we have to give the because here the drugs will be differ. So in antepartum, we have to give the drugs like hydrogen, nitrates, beta blockers, and if necessary, we have to go for the diuretics. So I will come across in the next slide regarding the delivery and all these things. If the patient is in postpartum, then we can give ACE, ARB, beta blockers, spironolactones, diuretics, and if necessary, we can give the ivabradine also. And again, I am telling that bromocriptine role is little controversial. It is depending on the individual and institutional based. And if the patient is having severe LV dysfunction with arrhythmias, then we have to consider for the wearable cardiac defibrillators. And in case of once you diagnose the PPCM, better to continue the treatment for 1 year or at least for the 2 years. So, as I told, the routine management of drugs in PPCM. So coming to the advanced therapies, so inotropes. So if BP is permissible, we have to give the levosimentamine rather than routine catecholamines, because levosimentamine is the calcium sensitizer, so it will cause the myocardial increase in contractility and peripheral vasodilatation, so that workload on the heart is decreased. That's why it is the drug of choice. So if required, then we have to, whenever the patient is in hemodynamic compromise, so IABP is a very good role, has a very good role. I think in our institute we have seen a number of cases. Whenever they present with a severe peripartum cardiomyopathy, so IABP has done very well work, and if you put for IABP for 5 days and ventilator, most of the patients, so after 5 days we have removed the IABP and they have came out. And if necessary, we have to go for the ECMO and LVAD. So if the patient is having severe LV dysfunction despite of treatment, so if the patient is fit for ICD, so we have to consider for ICD or CRTD, and cardiac transplantation is the last option. So despite of treatment, if the patient is having severe symptoms and if she developing complications, maybe at the end of the 6 months, we may consider for the cardiac transplantation. Regarding delivery, if the fetus and mother doesn't have any distress, then we can go for normal vaginal delivery. So if there is any distress, then we have to go for the cesarean section. So type of anesthesia, epidural is the preferred one. And early delivery is not required if the baby and mother is no hemodynamic compromise. And breastfeeding, again, this is one of the controversial topic. So previously everybody used to avoid breastfeeding once you diagnose the PPCM, but nowadays some of the studies are saying that we can give, but whenever the patient is having severe PPCM, severe LV dysfunction with the complications, better to avoid the breastfeeding. And so in mild cases, we may consider, so European ESC guidelines are saying 2B indications for regarding the avoidance of breastfeeding. So it is individualized. We have to take the group approach and team-based approach only, consider the breastfeeding decision. Coming to the prognosis, so once you diagnose the PPCM, 50% of the patients will have complete recovery, 25% they will have persistent symptoms, and 25% of the patients they will develop new complications like progressive heart failure, arrhythmias, and thromboembolism. And overall mortality rate is 3 to 9%. And if the patient is having persistent cardiomyopathy with symptoms, despite of treatment, even at the end of the 6 months, the mortality rate will be 85% in 5 years. So follow-up of the patients. So once you diagnose the PPCM, then once in a 6 months, we need to do the echo. And so once you diagnose the PPCM, so generally heart failure drugs are routinely given. So the 4 pillars are SGLT inhibitors, ACE-ARB, mineraloreceptor antagonists, and 4th one is the beta blockers. So generally SGLT inhibitors, generally will be avoided in postpartum cardiomyopathy, either pre or post delivery. So other drugs like once you initiate it, so MRIs after 6 months, if the LV functions improves to normal, first drug we need to withdraw is MRA till the end of the 1 year. After 1 year, so if still LV function is normal, then we can withdraw the ACE-ARB or ARNI. So beta blockers are generally continued till the end of the 2 years. And if the patient is again going for another one more pregnancy, then it is better to continue the beta blockers rather than stopping. So now the thing is, what for the next subsequent pregnancy, what to do? So here it is divided into 2 groups. If the LV completely recovers normal, one group, and another group is they are having persistent LV dysfunction. So if the LV is completely recovered, means here also recurrence chance will be 20% is there. But here the good thing is mortality and morbidity is slightly lower, and they will have likely to have a normal delivery. However, we have to counsel the patient definitely regarding the relapse and all these things. So if the patient is having persistent LV dysfunction, means here the risk is very, very high. 50% of them have again PPCM during the pregnancy, and here the thing is they have very high mortality and morbidity, and they will land up with most of the patients premature delivery and abortions are more common. So here counseling of the patient is very, very important. Thank you.